Welcome to Intonicated, a podcast about psychedelics, learning, and well-being. Intonicated is an adjective that describes a heightened, expansive, and health-affirming state of consciousness marked by clarity, vitality, and integration, in which a person feels inwardly attuned and stretched towards deeper awareness, emotional resonance, or spiritual growth. I'm your host, Ken Tupper. Please be sure to like or subscribe. Okay, thank you, Jonathan, for joining us. This is Intonicated, a podcast that has conversations about psychedelics, learning, and well-being. Super pleased that you're able to join us. Wondering, first of all, if you can just briefly introduce yourself.
Yeah, my name is Jonathan Dickinson. I'm the CEO of Ambio Life Sciences, and we provide ibogaine treatments. We've got about 6 clinics down in Mexico, and we just opened one in Malta. And so we work with people for a variety of reasons coming down to do ibogaine.
Awesome. Okay, well, first off, the title of this podcast is Intonicated. I gave you a brief overview of that term, how it came to me in an ibogaine session that I was privileged to be able to experience. I'm just wondering if you can react to the word as I've kind of described it to you.
Yeah, I appreciate it. I think, I think it is true. Like we need to be able to think about altered states with a little bit more subtlety and depth. And one of the challenges is that a lot of the experiences that we have, we don't have a very strong language to be able to navigate that. So I think we can try to borrow sort of from languages that do. And in other places, I think we just maybe need to create some new language for it. So I think it's a good start. You'll probably need like a TikTok rapper or something to really get it to stick. But I think, yeah, I think it's a good start. Yeah.
I don't think that's going to be me, but
Yeah.
do you have any experience personally that you can think of that sort of resonates with that term? It's fine if not, but I just thought I'd ask.
Yeah. I mean, I guess the most obvious it would be around microdosing and the sort of subtle threshold that we reach. I think because like, sometimes we talk about microdosing like it's subperceptual, but the times we do kind of rest on this very sort of subtle threshold of starting to feel some effects and starting to skirt the edges of a different kind of perspective. So our thoughts are a little bit more fluid and we can start to see some dimensionality, but we're just sort of going throughout the day. So we're not still kind of like overwhelmed by that. And so, yeah, I think that's what it first brings to mind. But I'm sure that even in deeper states, when we're able to strongly focus a lot of energy that's coming through to us, I think it's really valuable to sort of think about that not as necessarily toxic, but something that's certainly helping us in a very deep way and sort of structuring how we work with energy in our mind and our body. So I mean, I have lots of experiences with it. One of them is thinking about even the state of being in a Santo Daime ceremony and just sitting in the chair. And I don't know if people are not familiar with Daime, but it's very brightly lit.
Well,
There's
first, that's
music.
ayahuasca.
Yes, and also, yeah, and you're drinking ayahuasca in the setting. We're sitting in chairs with lots of other people, reading hymns. There's somebody will get up every once in a while and give essentially a strong sermon about, in this case, he was talking about concentration. And I had a moment where essentially I just got mauled by a jaguar, kind of came out of nowhere and just started like eating my face and everything. And the whole thing was just about concentration, and sort of all of the challenge and the intensity that was coming up was about trying to find like points of focus, like to bring things down into what was left of me and what was essential. And yeah, I thought that was really useful. So, like, on a day-to-day level, if I saw something like that happen, I would think I was intoxicated. But there was something clearly driving behind that, like a helpful force that was attempting to sort of show me how strongly and intensely I could focus my mind, even
Interesting.
despite
Okay.
chaos ensuing.
Yeah. Yeah. Thank you. Um, what got you interested in the topic of psychedelics generally, originally, and then ibogaine specifically?
Well, I got interested in psychedelics because of reading literature. Um, when I was in high school, I came across a book called Writing on Drugs by Sadie Plant, and it was like a history of Western literature and all of the drugs that sort of famous authors had been inspired by when writing works that most people are familiar with, like Frankenstein by Mary Shelley, who's drinking laudanum, and um, you know, there's a lot of other,
Coleridge. Yeah.
yeah, sure, and there's more obscure works, but that were very influential in literary circles, like Kubla
Yeah.
Khan and all that. But
Yeah.
or at least now they're only influential in literary circles. But I think, that sort of sparked my mind at a time when I was really sort of starting to understand literature in like a much deeper way and understanding all these levels and depths of, what people were actually creating, you know, when they were writing and probably the things that they were thinking about and designing into those worlds when they were crafting them. And I realized that they were benefiting from obviously these states and being able to be transported to kind of other worlds and other experiences was sort of the appeal of literature
So,
as well.
so why psychedelics then, and not laudanum? Was that pursuit
So
of interest?
yeah, because I think that if you look at like the signals from the culture about or the subcultures that use different drugs, psychedelics seem to be the most aligned with that, with the most aligned with really interesting multidimensional stories coming out of it, where other sort of substances like, you know, laudanum is opium and wine. So, I mean, taking opiates to me didn't seem very appealing because it seemed more about sort of being obliterated or sort of wiping out pain. But this wasn't really what I was interested in. I was really interested in these sort of states of consciousness and this feeling of being transported. And so that's what interested me originally. And then I got put on antidepressants, like, yeah, I had a little time where I was a little bit pissed off in high school and ended up just getting a doctor's appointment where they gave me like a 10 question, or sorry, 9 question questionnaire, and they prescribed me Zoloft at the end of it. And then that was like a 2-year process of going
Was it
from one
helpful?
antidepressant to the other. No, it wasn't helpful very much at all. I felt high the whole time. Like, I felt like, people describe feeling kind of numb, and that resonates with me. I think I felt sort of like most of my experience was sort of concentrated to the sort of narrow bands, and I was kind of felt like I was up in my head a lot, like kind of looking down at myself almost. So this is a very So it was altered. So I think that was kind of maybe interesting at the very beginning, but it was so monochromatic and fixed that it quickly became, yeah, really kind of disabling. And then the worst was like once I told the doctors, like, I don't want to take these anymore. And then going through withdrawal. And I had a really bad
Mm.
withdrawal. And it wasn't until, I
Did you
took some.
taper?
No, I didn't. I just cold turkey stopped. I didn't know anything about
Yeah.
it. They didn't really tell me anything about what they were like going on them. I told the doctor before I stopped taking them, and he didn't tell me anything about tapering them off either. I was talking with
Mm.
GPs, like, who were, this is how psychiatry works, is it gets diluted down into like diagnostic categories, and then people who don't have psychiatric training for the most part are the ones discussing and diagnosing. So, um, anyways, yeah, the withdrawal was protracted and difficult. And then I had a turnaround experience taking mushrooms with my friends in a park in downtown Ottawa. It was a wonderful experience. I sort of had a moments of telepathy and just like all these things I was really interested in, potentially altered states of consciousness and extrasensory perception, and then just also a moment with a tree, like just looking at this tree and realizing that it was alive and I'd been walking by it every day and just feeling it breathing and just kind of more than anything feeling myself, rather than just the tree, just feeling my emotions about being awake to the world around me. And just wept from that and kind of released these floodgates. And it really kind of turned me back on to realizing that I was real and the world around me was real. And that I felt like excited about the journey ahead of me. I was still young, so that turned me on to psychedelics. And
And then
then I
where did you come
followed that
across
thread.
Ibogaine?
Yeah, so I met you before I came across ibogaine. I think I was working for the Canadian Students for Sensible Drug Policy. And
Yeah.
at the time, I was very interested in psychedelics. So I kept trying to bring psychedelics into this conversation. But CSSDP was focused on drug policy more broadly. And at the time in Canada, most of the work and the attention was on things like the supervised injection sites or the Naomi trials that had just published, and other kinds of.
Heroin prescription trial.
Yes, that's right. Yeah. Um, and then just generally harm reduction and, peer drug user groups and that sort of part of the world of drug policy. And we were organizing national conferences, which I think at the time were the only national conferences in Canada where we were talking about drug policy at all. So I got exposed to a lot through that stuff I was still very interested in, just because of the sort of fundamental issues about cognitive liberty and human rights. And there's a whole profound kind of social justice issue around how we deal with drugs and regulate them and prosecute people who use them. But I kept trying to bring people to talk about psychedelics into the same conferences. So eventually somebody told me about Ibogaine because it was a psychedelic that had been really developed and taken forward by the same kinds of drug user unions and the same sort of harm reduction circles, actually. And so I was able to make a
Although
link
not as a
to.
harm reduction intervention per se, but as a treatment for opioid use disorder, right?
That's right. Yeah, it was like a treatment, but so many of the early advocates were from the harm reduction world. And, Howard Lotsoff, who was the man who discovered that Ibogaine could mitigate the withdrawal from opiates, was a big advocate for methadone before methadone was approved and widely available for people. So it was a strong overlap. And then the early treatments that were happening in the late 80s were in an organization called ICASH, the International Center for Addict Self-Help in the Netherlands. And it was a drug user union that was making these treatments available. And I think where the harm reduction angle came into that was around the idea that um, was very sort of non-judgment about whether what the outcomes needed to be from treatment.
And then using a psychoactive drug to treat a drug addiction, that's
Yes, at the time, yes,
out of step with
exactly.
the sort of 12-step abstinence-focused modalities that were being promulgated at the time.
Absolutely.
So,
Yeah, I think maybe less so now, but but yeah, that was the overlap. So that's how I got connected to Ibogaine, and then through the links around CSSDP, I got connected with clinics in Mexico, and so I came to Mexico, been like 23 or something. Like I kind of grew up at those clinics and built myself and my career around apprenticing, doing that kind of work hands-on with the people who were, um, the I call them like the second generation of Ibogaine providers. So there were people who had gone through treatment and then had enough street sense and, organizational capacity and compassion to be able to redesign the treatments in a better way and elevate that into practices that they were uh, providing treatments either out of their home or out of very small clinics and stuff. So those were the people who I spent time apprenticing with in Mexico.
and the first generation was Howard Lotzoff in the circle that he was working in,
Yeah, yeah,
or
there
the
were sort of
Netherlands folks.
earlier advocates, and there was a mix at the time, actually. It was some of the biggest, I would say, like first generation providers were like Richie Ogolnik, who was going by the name Eric Taub, and Sarah Glatt, and neither of them were folks who were using opiates. They just, for some reason, saw it or heard about it and understood what it was, and then just went, full into providing treatments. And they treated a lot of the people who became that second generation of providers.
Right?
Yeah.
Did you have an Ibogaine experience yourself at that time?
When I went down to Mexico, I was working with Claire Wilkins. She, at the, she's spoken about this publicly. She's had several deaths before because it was at a time when there wasn't very much known about the risks. There was some, but they didn't really understand the mechanisms about what would have caused fatalities or the need to hospitalize patients. And so,
Yeah, I wanted to come to that, but maybe we can go here now.
yeah, so that was at that early stage. So nothing had been really written or published, or not much. And I think she had three fatalities at the clinic. And so in the process, her one of her responses was to develop a different dosing protocol where instead of working with a flood dose, because normally with Ibogaine, you kind of go in, people are taking opiates right up until just before treatment, and then there's a window, like half a day or 6 hours or whatever, where there's no opiates, and then you give Ibogaine, a large enough dose with the intention to break the habit completely.
Hmm.
And what Claire was doing was experimenting with, rather than giving a massive dose, which she felt like was, compounding the risks, she would give a smaller dose and then put people back on opiates, which would actually stabilize the hearts and everything again. So, but at a smaller dose, because you would resensitize the body a little bit, and so you wouldn't need as much opiate to sort of come back to homeostasis, and then do it again and do it again and do it again, sort of repeatedly stepping people down in this accelerated taper and
Mm.
gradually increasing the ibogaine dose as you sort of
Like
saw
a
people respond to it.
off ramp, on ramp kind of. I'm visualizing. Yeah. Okay.
Yeah,
And how
and
did
then
that work?
yeah, so she was developing that, and I think that it worked in her case. I mean, she didn't have any more fatalities. Like I worked with Claire very closely for 6 years, and the treatments were a lot safer. Like she even didn't need the same kind of intensity of the infrastructure of like all the doctors there on treatment and I sort of huddling around. She kind of felt like maybe that was even contributing to this error of taking too much risk, especially at the time. Again, people didn't really understand what was causing those issues. And that came out later, so I went down in 2009, and it was 2015 we wrote much more comprehensive clinical guidelines on how to mitigate risk because there'd been a better understanding about how ibogaine affects the heart and all that.
That was your work with GITA, or the Global Ibogaine Therapy Alliance? Yeah.
Yeah.
So
So
could you just go back to your first experience with ibogaine? Was it
yeah.
with
So my
Claire?
first experience was with Claire, and she wasn't that keen on giving me a large dose because I didn't really need it that much. So I got to experience sort of the way that she was working with smaller doses for quite a long time, actually for years. Like we would work with small doses, experience what it's like building up the way that she did with patients, what it was like working with boosters. So I didn't have sort of a singular, massive, transformational experience with it. But I mean, I kind of understood the territory and the aesthetic and what things looked like, and became very familiar with that and the language of it, especially doing that myself and then talking to patients and things. So, my first experience was fairly small. I remember I walked down to the beach because it was near the clinic, and I sort of heard this sound like doo 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 doo. And I thought there was a helicopter like out in the water because we were in Tijuana, and so at the time helicopters were patrolling the border. And now they're not there. They must do it with drones, but at the time there was helicopters all the time flying around. And so I thought there was one, like I was looking for it out in the water, like behind the waves, and then realized that's too low. There's not a helicopter flying right on the water. And then realized that that was the buzzing sound that people had talked about. It was just way lower pitch, like doo, 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 um, lower frequency, lower pitch. And yeah, then I realized that it was coming on. I need to walk back to my bed and lay
before
down for a little.
before you couldn't walk at all?
Yeah, because I thought, I was watching patients take those kind of doses after their flood dose as booster doses, and they were walking around the clinic and watching TV and stuff. So I didn't know that I was affected by it very strongly.
So can you tell me more about the Global Ibogaine Therapy Alliance? I think you were the executive director for a number of years.
Yeah, so I mean, that was sort of the early days. I was learning about ibogaine, and I was making smoothies and sweeping the floor and just helping around the clinic and kind of learning and absorbing whatever I could. But very quickly, I realized, especially because of all of these safety discussions that were going on, I realized that some of my previous um, whatever knowledge about organizing with the Canadian Students for Sensible Drug Policy, putting together conferences and whatnot, would be really helpful for the ibogaine community. So we organized a conference of ibogaine therapy providers in Vancouver in 2012, and essentially it worked like in the medical field, they call them M&Ms, so like mortality and morbidity conferences. So that's where you talk about situations that didn't go well or that resulted in deaths. And so there was historical literature to talk about, and there was
Mm-hmm.
also two new recent cases. So there was one provider there to talk about a death that had happened, and there was a patient who had been hospitalized and there to sort of talk about what had happened to her. And it was also shortly after there was a Dr. Kenneth Tupper at the New York University who had done a forensic study on 19 fatalities that had happened previously with ibogaine, and sort of unpacked um, the coroner's reports and talking to the providers and whatever data that he could come across. And he sort of narrowed it down into several key conflicts. Like one would have been the cardiac issues, and then the other would have been drug interactions. And there was another that was sort of specific to withdrawal from alcohol and benzodiazepines, where there's generally quite a lot of risk in withdrawing from those, and it's protracted. Ibogaine does not help with withdrawal from benzos, or at least not acutely like that. And so there can be a risk of seizure. And then if somebody's having a seizure while they're on Ibogaine, it's a cardiac risk.
And yeah, that's not even to do with ibogaine. You're talking generally withdrawing from alcohol and benzodiazepines, or
Yeah,
it's
and
a much more
Ibogaine
risky undertaking.
doesn't help because my sense is that it does something to like lower the seizure threshold or something. Like it makes it potentially more likely that somebody could have a seizure if they're withdrawing from benzos.
Mm.
So there was all kinds of things that we learned from that. And at that conference in Vancouver, we sort of formed the Global Ibogaine Therapy Alliance as a institution, like a formal organization. And I kind of took the helm with a large board of providers and other researchers and stuff. And, it took some time, but eventually we were able to put out those clinical guidelines through processes of community engagement and several rounds of intensive feedback. And then I think that's been a big transformation in the space generally. It doesn't, I think it's dramatically, I don't think it alone, but I think it has the conversation and everything and the increased knowledge and the clarification through that document and everything has contributed to a much, much lower rate of mortality and morbidity with ibogaine, especially when people follow the guidelines all the way and are doing it under constant cardiac monitoring and stuff, which is, I think, becoming well understood by,
Is best practice.
yeah, I think people generally understand that that's what you're looking for if you're looking to go do Ibogaine at a clinic. Yeah.
Yeah, I was going to ask the Global Ibogaine Therapy Alliance best practices guidance. Did they mostly have it kind of figured out by then in terms of how to mitigate those risks, or has there been ongoing sort of stepwise improvements of understanding and further ways to reduce risk?
Well, there was a lot of discussion to be had because most of the providers were not doing constant cardiac monitoring. So we wrote it like, look, these are just the guidelines. Like, you certainly will mitigate more risk if you use constant cardiac monitoring. So that's what we'll put in here. This is the most that you could do to mitigate that risk. There's certainly a lot more detail, and like, at Ambio, we've worked out in much more granular detail, and there's issues, right? Like, for one, some of the exclusion criteria that we listed in the guidelines, we don't we don't stick as closely to that at Ambio because understanding we're what's actually happening and in a more detailed, focused way, we're able to mitigate the risks and understand them better than we were before. And we were really writing that guideline for non-medical providers, which was the norm at the time.
So you're taking more of a
So,
kind of precision medicine approach now with
yeah.
sort of understanding each individual patient's unique circumstances and sort of dealing with that. Yeah.
But there's also
So,
things that have changed that we didn't write about, like fentanyl wasn't as prominent. And so there certainly wasn't all of these new emerging synthetic opioids. And so I think there's still large risk around drug interactions. Where the cardiac stuff, I think we can respond. I think we can mitigate that risk. There's more risk around drug interactions. And then related to that, we started working with more like military guys and just guys who spend a lot of time working out, but especially people who are taking testosterone or maybe taking a little bit more testosterone than what's generally prescribed, or taking steroids or other things to try to boost their workout. So there's potential kidney issues that we didn't write about and that we've seen
mm,
more prominently in this population than we would have in the populations of people using opiates and stuff. So, but I
right.
think, you know, we've it could be updated, but it provides a good general skeleton for like a harm reduction guide for non-medical providers. And then most of the clinics have been able to use that as a skeleton and sort of dial it in.
How about the co-administration magnesium as a prophylactic for the cardiac issues? Was
That
that in
was,
that?
yeah, that was written about in the guidelines as well. That was something that was going on for quite a while, for decades. And yeah, you know, the general thing is that the heart uses electrolytes to regulate its heartbeat. Electrolytes are ions, so they're either positively or negatively charged, so they kind of push the electrical impulses on and off. So one of the things that ibogaine does is it reduces the amount of potassium that's getting into the cells, and so it slows the repolarization of the heartbeat at a certain point. So you notice this like extension of some part of the heartbeat, which slows the heart rate, but eventually it leads into problems, right? And so if you front load the body with a lot of magnesium, it actually helps potassium get absorbed better into the cells and sort of prevents that prolongation from happening the same way. And yeah, it's a standard practice in cardiac medicine. If
Yeah,
somebody's having one of these arrhythmias, you administer IV magnesium. That's what you do. So all that we're doing is doing it as a prophylaxis at the front end because we're
right.
anticipating those kind of reactions.
So can you tell me more about the companies that so after Global Ibogaine Therapy Alliance, you started Terragnosis and then Ambio Life Sciences. I don't know which order those came in. And yeah, just tell us more about what led you to seek opportunities in developing those companies.
Yeah, well, Terragnosis has basically been helping to build the supply chain for ethically sourced ibogaine. So that was one of the other issues that GITA had to deal with early on was in addition to the safety challenges, there was also sort of signals from Gabon that there was economic and ecological impacts of the demand increasing for ibogaine. So one
And that was before there
example,
was really big demand. Like it
yeah,
was
that
not as
was
much
right.
as
That's
now.
right.
Yeah.
That's right. So a lot of the challenge, like I think we rerouted a lot of the supply chain early enough that the demand hasn't continued to have the same degree of catastrophic impact that it would have. And so part of the problem is that in Gabon, there's just not a lot of history of agriculture. Like villages are very much just like hunter-gatherer, um, and then they sort of live on the edge of the highway and trade, but have access to the forest behind them and live
More
off of the
subsistence.
land.
Yeah.
Yeah, and the forest is abundant. You don't need to cultivate a whole lot because you're basically just harvesting what comes from the forest. So there's lots of fruits and animals and um, palm and all kinds of different sources of nutrition. I think the main thing that people did cultivate was cassava for the leaves and the roots.
Mm-hmm.
But yeah, ibogaine, or in its plant context, it's iboga. Ibogaine is one of the alkaloids in the root bark, and so iboga would be growing like sort of close to the village and then further back and whatnot. So what was happening was as there became a trade, so like along the highway, people would come down and sort of purchase stuff. So people would start to carve back into the forest, like further and further to be able to supply some kind of demand and like make a little bit of money to trade. And then in the central markets, the price would be going up, so it would sort of drive more demand from the inland as the market grew, right? It's just basic economic forces. But the problem was that there was no more cultivation of iboga happening, so it just kept pushing further and further back, and it's going back into like protected forests that were part of there's like an extensive network of national parks
Mm-hmm.
in Gabon that's been protected, and this rainforest is like It's like the second largest to the Amazon. Uh, But so then it would sort of get mixed up potentially in all these other poaching activities that were going on in the big forest, like, animal tusks and um, other kind of like rare lumber and things like that. It would be
Mm.
caught up in all this sort of illegal trade. And so that was concerning for a whole bunch of reasons. And one of them being just became too expensive for traditional practitioners to be able to carry on ceremonies and carry on the practices. So there's sort of a
In the
cultural sustainability.
Bwiti tradition.
Yeah. It was like, so it's unsustainable to continue that
Okay.
way. And so
Yeah.
there's an organization led by Jan Guyon called Blessings of the Forest in Gabon. And they have done an incredible job of alerting people to that fact and encouraging people to plant for their own use and then also for surplus to be able to participate in a regulated market.
Hmm.
Um, and they've been quite successful, I think. They've got many villages within their own purview, and then there's also larger farms throughout the country. And so I don't think we're any more worried about iboga being taken from the private domain. Like, it will exist, but it's still being poached from the public domain, like from the parks and things like that. But Terragnosis was eventually granted an export license, the first export license that Gabon issued, and it's through something called the Nagoya Protocol. So it's designed to sort of provide access and benefit strings back to traditional communities, which means that not only are they getting a fair trade sort of pay, but they're also receiving benefits from the external use. So it's like you pay for the material first, and then you provide like some benefit from the way that we use it outside. So yeah, so we've been doing that, and Terranosis is generally involved even with like alternate sourcing for ibogaine to make sure that we can meet the scale,
The
of the
rising
demand as
demand.
it grows.
Yeah.
Yeah, that's been something that we've been tracking and working on. So that was Terranosis. That was the first one that I. Yeah, so Ambio formed. I mean, there's three of us who kind of came together to create Ambio. All of us had been, at that point, 10, 12 years in the field providing ibogaine. And we came together because of a demand from the veteran community, specifically the Navy SEAL community who was looking for somewhere to send patients of theirs. Um, there's a great movie about it out now on Netflix, so you can see the whole journey of Marcus and Amber Capone and how they first noticed the change that Marcus felt and then started fundraising to send other guys down. And that's what the movie's about. It's about them sending some of their teammates down. And that's just happened at a wildly successful scale. And then the Navy SEAL community has touched other parts of the military community, but also, they started bringing in pro athletes and stuff. And so what we have been able to see a bunch of things. Like, one is we've been able to see what ibogaine is doing when people aren't on opiates. So before, like
Because
most of the
most of those,
changes, yeah, most people were taking opiates or drugs. So any changes in their health status, we would have attributed probably mostly to the fact that they stopped using all these drugs, with few exceptions. So, I mean, with the veteran community, yeah, very few guys were taking opiates. That wasn't really the issue. I mean, some of them are drinking alcohol and stuff, but they were able to stop before they came. It was, they were on psychiatric medications, but nobody was under the impression that that was causing their issues. That was the way the system had responded to try to treat what they'd been diagnosed with, which was PTSD and depression and all this stuff. So what we were able to see was what was happening to them and this large transformation that was going on, even when drugs weren't really the primary factor. And we did a study with Stanford University, So they did brain imaging with these guys before and after they came down, and showing that, all these guys who are out in the global war on terrorism have been exposed to traumatic brain injuries just because of explosions and high caliber weapon fires, being close to things that would send small shockwaves through the brain tissue and create pressure against the skull, and it creates this kind of cellular damage. And so, it seems like it's interesting because like a lot of the discussion that we have about how to support veterans is mostly about psychiatric issues like PTSD, which are widely diagnosed in the general population. But then what we're seeing is actually the sort of signature wound of having been in combat is this traumatic brain injury, which has a lot of the same symptoms of PTSD, plus neurological symptoms like light sensitivity and headaches and things like that. So we were able to see big changes, not only with their symptoms and the way that they were, what they were describing their life was like before and after treatment, but also on their brain scans and showing a cellular repair and regeneration of that kind of damage. And so that strongly related to a lot of the athletes that they started to bring in who had similar patterns of cellular damage because of playing sports, where you wouldn't expect, somebody who was in the NHL to have PTSD from like living a great life and, living out their dream. But they're actually having some of the same challenges in retirement that the military guys were experiencing.
Right. Yeah. And it also makes me think of the original explorations of ibogaine as a treatment for opioid use disorder and the kinds of brain injuries that have appeared, particularly with the rise of fentanyl and overdose survival through, valuable life-saving interventions like naloxone, where people who are surviving overdoses are sometimes left with anoxic or hypoxic brain injury. So sort of maybe ongoing active opioid addiction and a similar kind of brain injury that perhaps ibogaine could be helpful in treating both at the same time, both the addiction and the brain injury. I think lots to be done by way of basic research to advance that, but it's super promising based on your work already.
Yeah, I wouldn't
Can
be
you also
surprised at all. I think that's why we get this opportunity now to try to understand. Like, I think if we understand what it's doing, like why it's helping in a more specific way, like we had to understand the risks and how to mitigate the risks. But if we can understand the benefits and how we're achieving those benefits better, we can optimize the treatment quite a lot still for different use cases. So I think it's,
and you've got a neurodegenerative program now looking at Parkinson's and MS symptoms.
yeah.
Can you say a bit more about that?
There was some early signals about Parkinson's that came from the community more broadly. There was one patient in particular back in 2014 who took microdoses of ibogaine for his Parkinson's. He had atypical Parkinson's. It means he didn't have a tremor, but he had numerous other symptoms, like he had rigidity in his face. He was losing his balance when he would stand up. He lost a lot of like fine motor coordination, so he couldn't like do that kind of screwdriver motion to use a fork or things like that. And after 30 days, he was noticing major improvements in all these symptoms. And so I stayed in touch with him for like 6 years. Even though I wasn't originally involved in his treatment, I followed up with him and stayed in close contact. And yeah, he didn't want to stop microdosing because he kept having these benefits. And it was almost like if, in his case, the Parkinson's progressed much more slowly. And I don't even know that it ever got back to the point where he was pre-treatment.
Uh,
So it gave him a lot more quality of life in his later years. Um, And then we didn't see a lot of people with Parkinson's generally because there were sort of here and there somebody would come who'd heard that story or something like that. But what we did start to see is more people with multiple sclerosis just because that gets diagnosed when people are younger. So this is another example of potentially changes, benefits that we would have maybe previously attributed to people being on opiates, or they might not even have known that they had these other conditions or whatever. But now we were able to see what it was like for somebody who just had MS that was maybe interested in other childhood trauma or something like that, and also had MS going through and then noticing these big changes. So we were able to capture some brain scans from some of the patients that came through and noted, like on fMRI, big structural changes in the brain that happen very quickly, much more quickly than we're used to seeing changes, especially in like white matter areas of the brain that are heavily affected by MS. Because what MS is sort of characterized by this demyelination. And so myelin is sort of within that white matter. It helps, it's like helping to conduct electrical signals between all the other parts of the brain. And so that's what is getting degenerated in MS, is this ability for the brain to signal between regions. And so you have this sort of like network effect of things not working as well as they were before. And then, so the ability for a drug very quickly to come in and affect the structure of the white matter was super promising. So there's been, other cellular studies that have been done elsewhere. There's some that we've gone back to try to do, again, to try to understand if we can hone in on what these benefits are, then we can rapidly improve the care. And so the neuroregenerative program is the first sort of major iteration. It's like version 2 of like, if, now we're trying to treat 2.0, of like we're trying to treat people with these conditions. And so we're not doing flood doses, we're doing lower doses, and then they're followed by microdosing. And people are sort of focusing in on what makes sense as far as ongoing microdosing. And yeah, we've seen, it's very experimental. The program is designed to sort of accommodate people who are either older or they have mobility issues. And that's what we've done, right? It's like, this isn't, we can't make claims about treating these things. It's still properly just anecdotal evidence that we're dealing with at this point. Like we've got, I don't know, maybe we're approaching 100 overall across all those conditions, but it's still very early days for us to start drawing any major conclusions. And we try to communicate as best we can about what people do see and how they can improve the outcomes. But
there's enough of a signal, I guess, that word of mouth sharing of this is happening amongst people with those conditions.
Yeah, I think so, especially because it's fair, like some amount of improvement is fairly consistent in people who are taking Ibogaine, while no improvement is fairly consistent amongst people who are not taking Ibogaine, right? Or like they get to a point where their options are, especially for Parkinson's, it would be like direct brain implants which have massive side effects and stuff like that. So,
right.
So that's, I think, what's driving that interest. And yeah, it's been, just incredible. It feels like we're at a really interesting time for Ibogaine, and it's kind of like all upside. I think we have a lot to learn about what the limits of what it can do are and what else maybe it can do. Because, we've seen like other one-off cases like for Tourette's and lupus and all whatever, just like random things. But ultimately, we don't know, are these one-off cases because there's some psychosomatic mechanism here that we can't replicate, or are there other health things that like, we do have to start to think of the brain and the body as a much more systemic and integrated system rather than like single targets. I think that's why Ibogaine works, is because it does treat the brain as an integrated system rather than working on a single target. But we still have so much to learn on how to optimize this.
Well, I think we're coming up to the sort of time allotted. I was going to ask you about research directions, but maybe I'll have you back in future. We can talk where things are going. It sounds like there's lots of excitement and now investment happening in that area. So
yeah, there's stuff even going on over the past couple days that I got to go catch up on. But yeah, I'd be happy to talk more about it soon.
Yeah. Okay. Well, keep up the good work. Thank you again so much for joining us, and we'll stay in touch.
Thanks, Ken.
Right on. Bye-bye.
Content in this podcast is for informational and educational purposes only. It is not intended to provide medical advice, diagnose, treat, or prevent any disease. Always consult a qualified healthcare professional before making decisions about your health or the use of any substances discussed here. Psychedelic substances remain illegal in many jurisdictions. Listeners and viewers are responsible for knowing and complying with the laws in their area. The views expressed by guests are their own and do not necessarily reflect those of the hosts or affiliated organizations. If you choose to explore these topics, please do so with caution, respect, and awareness.